Okay, let's continue the integumentary for pathophysiology. This is video recording number 2. Um, we are going to continue with infestations. And first, we have pediculosis, which is also called lice, that can infect the scalp, the body, the pubis area, and also the eyelashes. Head lice is transmitted by close contact. The body lice is transmitted by crowded conditions. The pubic lice are transmitted by sexual contact, and the symptoms and signs basically vary depending on the location of these infestations. Lice is basically wingless, blood-sucking insects that infect the head. And when it infects the head, it's called pediculosis capitis. When it infects the body, it's called corporus. And when it infects the pubis, it's called lice pubis, or pediculosis pubis. There are three kinds of lice that differ substantially in morphology and clinical features depending on the location. Very pruritic, as you could imagine. Head lice is very common among girls, pediatric population, but it could be present in adulthood. Infestations are very rare in Black African Americans. Is transmitted by close contact. Is rejected by um, certain static electricity, or if the patient is dyeing the hair. Is transmitted also by sharing combs and brushes and hats. And again, the main symptom will be severe pruritus. And of course, by scratching, the patients would have in the scalp excoriations, and also if it's too invasive, patients could have cervical adenopathies. The treatment, as you could see, is basically using lotions and creams. Um, Drug resistance is very common. It should be managed with oral ivermectin, which is not specified here, but you would see that in pharmacology. Topical pediculicides. The needle has to be removed by a very fine tooth comb and during wet hair. You could use chromatibone, you could use lindane, you could use ovide or permethrin, which is elamide. Same with body lice and pubic lice. For example, the pubic lice, which is transmitted by sexually transmitted disease, um, but it could also be transmitted to children by close parental contact. They're also transmitted by towels, sharing towels, bedding, and clothing. Um, Perianal hair could also be affected. And of course, patients would have severe pruritus and regional lymphadenopathy. Eyelashes also could be infected, and patients could have eye itching, burning, and irritation. And the diagnosis is basically by demonstration of the presence of the needs and the adult lice, or it could be done by close inspection with wood light. Now let's talk about scabies, which is another type of infestation. Scabies is also a very contagious disease. Um, is basically produced by Sarcoptes scabiei. Is a type of microorganism that produces this. Causes intensive pruritus, and also erythematous papules and burrs. You're able to see the channels, the tunnels that this mite will produce. Is very commonly present in the web spaces, and the method of highly contamination is by handshake. That's the most common way of contracting or acquiring scabies. It's present in the wrist, in the waist line, and also in the genitals. In the pregnant women's, for some reason, loves location of the breast and the belly. Etiology, as I said, is basically caused by the mite, Sarcoptes scabiei. Is an obligated human parasite that lives in borer tunnels in the stratoscornium. Scabies is easily transmitted from person to person through physical contact. Animals and also fomites transmit the infection as well. The primary risk factors is crowded conditions, patients that uh, are in school, such as the pediatric population, shelters, also in the household, because if one person acquires scabies, it's transmitted to the rest of the household. There's no clear association with poor hygiene, so this is completely erroneous. For unknown reason, crusted scabies is more common among immunosuppressed patients, those patients that have HIV or cancer or that are exposed to immunosuppressants or chronic use of corticosteroids. Basically, the diagnosis is by microscopic examination of the eggs or feces, and the feces, the fecal matter is very, very pruritic. So you could basically cure or eradicate the scabies, and the patient could continue itching for 2 weeks or more. So it's highly contagious. Treatment basically is done by solutions, and rarely the scabies affects the face, so you're going to apply topical lindane or permethrin, or sometimes when it's resistance oral ivermectin from the head down. I'm sorry, from the neck down, because rarely affects the face. So basically, the patient is going to take a shower before applying this lotion from the neck down, and everywhere. It's basically in the web spaces of the finger, in the scrotum, in the outside the anus, anywhere. You cannot leave one space without this lotion. And you're gonna sleep with the lotion overnight, and then you're gonna wash it off the next day. You have to apply this to the whole family, and you have to wash and expose the clothing to heat. So it could be the sun, it could be ironing, but it has to be exposed to high heat, because otherwise the eggs would not go away. And you will learn this again in pharmacology. We talked already about pediculosis, and these are examples of, you can see it in the web spaces of the fingers. Very common, since the first most common area of contagious is the handshaking. You're able to see the tunnels, which are called burrows, burrows, that the female of the Sarcoptes scabies does during the nighttime. So you could imagine that the pruritic, the itching, the severe itching that these patients would have is more intense at nighttime, when the females of the Sarcoptes is producing these tunnels to deposit the eggs. You could see the pediculosis capitis, examples of the eggs in the hair. Now let's talk about Lyme disease. Lyme disease is a tick transmitted infection. It's caused by a spirochete Borrelia Burgdorferi, and basically it could be produced by ticks, different types. There are actually 4 types that produce this worldwide. The Axodes scapularis, you don't need to know the names of these ticks. Is basically present in the deers in the northeastern and the north central of the United States. It's also present in Europe. In the mouse is also present an animal reservoir for Borrelia Burgdorferi. In the dogs as well, but it's more common in the deer. The deer tick is the one that most likely produces this. The pathophysiology of Lyme disease is that this Borrelia burgdorferi enters the skin at the site of the tick bite, and more or less 3 to a month after, the organism migrates locally in the skin around the bite, then spreads to the lymphatic through the lymphatic circulation to cause regional lymphadenopathies, and also could disseminate to other organs systemically, producing from meningitis to cardiovascular diseases, atrioventricular arrhythmias, and also could produce arthritis. Initially, what you would see is an inflammatory reaction that is the pathognomonic, is basically the hallmark of the disease, which is called erythema migrans. Occurs before any significant antibody response is present. So basically there are 3 stages. Just to have an idea, you're going to see this in more details when you go through your specialties. Early localized, that basically you see the erythema migrans, which is the best clinical indicator for Lyme disease, and it's actually the first sign of the disease, and this occurs in 75% of patients. It's basically a red macule or papule at the site of the tick bite that is usually on the proximal portion of the extremity or trunk. It has a very significant appearance. It resembles a bullseye or a target. You can see the picture right there that it looks like the target sign. Then it could go into, if it's not recognized and treated properly, it could go into early disseminated, where the patients could develop musculoskeletal symptoms, or like arthralgias, myalgias. Basically what they feel is like flu-like symptoms. They could have fatigue, chills, fever, headache, myalgia, arthralgias, up to frank arthritis. Patients could develop neurological abnormalities such as Bell's palsy, meningoencephalitis, and even radiculopathies. Myocardial abnormalities also are present in the early disseminated stage, and patients could have cardiac arrhythmias from first degree, AB block, up to third degree as well. They could have myopericarditis, they could have cardiomegaly, hypertension, etc. Late disease basically is more acrodermatitis, as well as more polyneuropathies, more encephalopathies. Diagnosis of the disease is basically by clinical evaluation, if you're able to see these erythema migrans, and also by blood cultures, CSF cultures, but you could also see that there's acute IgM antibody titers, but 2 weeks after the erythema migrans is present. And you would see the treatment in pharmacology that is basically based on amoxicillin, doxycycline, or ceftriaxone. Now let's talk about hemangiomas. Infantile hemangiomas are raised, red, odd, purple, hyperplastic vascular lesions that they tend to appear in the first year of life. Most are spontaneously involute without needing any treatment, but those that could obstruct the airway or could obstruct the vision, or they continue growing, could require treatment. The most common tumor of the infancy is this type of hemangiomas that appear before the first age of life, and basically symptoms are completely asymptomatic. It's just a bright red appearance, color. It could be bluish color as well. They grow, and sometimes they could bleed or they could ulcerate by any type of minor trauma. The diagnosis is basically clinical, and treatment is basically individualized. If the patient, just allow them to involute. If they don't, then you could apply intra-lesional corticosteroids or laser to make them involute faster. We also have the port wine stain that is called also nevus flammeus, which is another type of vascular malformation. They do not fade with the age compared to hemangiomas, and basically it's a malformation of the dermal capillaries. It's just a stain. Now let's talk about Stevens-Johnson syndrome and toxic epidermal necrolysis or Lyme syndrome. Basically, they're severe cutaneous hypersensitivity reactions. Patients that are exposed to certain drugs, such as NSAIDs, such as sulfa. Sulfa is actually the one that is most commonly present as an etiological factor for Stevens-Johnson and toxic epidermal necrolysis. But it could also be steroids, it could be antivirals, it could be anti-epileptics, it could be antibiotics as well. Macules rapidly spread and coalesce, leading to epidermal blistering, necrosis, and sloughing. And this basically occurs due to an apoptosis of the epidermis. The exact mechanism is unknown, but is basically a failure to clear reactive metabolites due to an altered drug metabolism. Some patients trigger T-cell mediated cytotoxic reaction in the keratinocytes, producing this type of symptoms. Basically, within 1 week or 3 weeks after the offending drug, the patient develops malaise, fever, headache, cough, and then start producing macules and plaques, often also in target configuration, such as Lyme disease, then start to spread and coalesce into a large flaccid bulla. That this bulla ruptures and the skin sloughs off. In severe cases, toxic epidermal necrolysis occurs, which are large sheets of epitheliums that slide off the entire body at pressure points. This is called Nikolsky sign. And they're weepy, they're painful, they're erythematous, as you could see in this picture. Okay. Now the staphylococci or Scalded syndrome is an acute epidermolysis as well, caused by staphylococci toxin. Infants and children are more susceptible, and the symptoms are basically widespread bulla with epidermal sloughing. Patients have acute exfoliation of the skin, typically following an erythematous cellulitis. Patients could have systemic manifestations of fever, irritability, and they also have Nikolsky sign. So basically you have to give antibiotic against the Staph aureus and hydrate the patient. This patient is basically treated as a burn patient. You have the pictures here. Now let's talk about benign diseases of the infancy and the newborn. And one is to basically miliaria. Miliaria is like sweat flow is obstructed and trapped within the skin, causing this type of skin lesions, if you could say. Miliaria most often occurs in warm, humid weather, but they could occur in cold weather as well. In an overdressed patient, like if you cover yourself very much, and in this case the baby, these lesions could appear. There are different types. The most common type is the miliaria crystallina, is the one that you're seeing basically, that looks like droplets of sweat. It's ductal obstruction in the uppermost epidermis with retention of sweat subcorneally or subcutaneously, causing clear drop-like vesicles that rupture with light pressure. The treatment is basically cooling and drying of the involved area and avoidance of conditions that may induce to sweating and trapping of this sweat. You could also give corticosteroid cream or lotions, but it's not necessary. Now let's talk about erythema toxicum neonatorum. It's basically a benign self-limited eruption occurring primarily in healthy newborn in the early neonatal period. It's basically characterized by macular erythema, papules, vesicles, and pustules, but resolves without any type of permanent sequelae. The pathophysiology of this is basically increased levels of immunoglobulin and inflammatory mediators such as interleukin. The water channels proteins, aquaporins, are also affected. Nitric oxide is released, suggesting that erythema toxicum neonatorum may be an immune systemic reaction. So it's an innate immune system response for the first time exposed to the microflora, and is self-limiting. The eosinophilic infiltrate of erythema toxicum neonatorum, suggesting also an allergic hypersensitivity reaction. So patients basically will present with an onset of the eruption with absence of systemic signs such as fever, irritability, lethargy. Infants with erythema toxicum neonatorum are otherwise healthy. They lack systemic symptoms. How do you basically diagnose this? You have to do a differential diagnosis among all the rashes, and basically no treatment is necessary. This is an example of milia, and this is another example of erythema toxicum neonatorum. Okay, and this is the end of the presentation.